Hello, my name is Pedro Peña. I want to thank you for taking part of my DNP project on improving clinical knowledge on the efficacy of brachial plexus blocks with perineural dexmedetomidine as an adjunct agent to ropivacaine compared to brachial plexus blocks with ropivacaine as a sole agent. It's an educational module, so I hope you learn a lot from the following slides. The learning goals. From this quality improvement module, you will discuss brachial plexus blocks, discuss dexmedetomidine, understand the effects of postoperative pain on patient outcomes, and identify the impact of pharmacological interventions in the post-operative period. Background. Brachial plexus blocks with ropivacaine alone provide analgesia for a mean duration of 8 hours. Studies have shown that brachial plexus blocks with ropivacaine and perineural dexmedetomidine provide analgesia for a mean duration of 12 hours. The mechanism of action behind this is that hypopolarized cation currents normally bring neurons back to the resting potential and normal function activity during the refractory phase in an action potential. By blocking these currents, dexmedetomidine can accentuate inhibition of neuronal conduction and produce analgesia. The use of alpha-2 agonists with local anesthetics has been proven to reduce the overall dosage, thereby reducing the risk of local anesthetic toxicity. So, what are the effects of inadequate postoperative pain control? Number one will be postoperative nausea and vomiting. It could also cause sleep disturbances. It could cause prolonged PACU times and delayed discharge. It could impair the immune system function, and it lowers patient satisfaction scores. It also increases VAS scores. Increased need for supplemental pharmacological intervention is also seen. The patients that have received supplemental pharmacological interventions with opioids have reported nausea and vomiting. They've also displayed respiratory depression with the requirement of supplemental O2. Their PACU times and hospital discharge times have been delayed, and they have a risk for constipation or ileus. So what is dexmedetomidine? Dexmedetomidine, or also known as Precedex, is a highly selective alpha-2 adrenergic agonist that is used in clinical practice to alleviate pain and induce sedation. Current evidence has found that 1 to 2 mics per kilogram of perineural dexmedetomidine is the ideal dose, and that any dose above 100 mics could cause hemodynamic instability. Studies have also shown that the addition of perineural dexmedetomidine lowers plasma cortisol levels, lowers plasma substance P levels, and lowers inflammatory markers such as IL-6 and IL-8. There's also lower reported rates of rebound pain. So how will perineural dexmedetomidine impact patient outcomes? According to the latest evidence-based research, a brachial plexus block with 0.5% ropivacaine and 1 mic per kilogram of perineural dexmedetomidine has shown to prolong analgesic effects, prolong motor and sensory blockade, shorten the speed of onset, decrease the needs for supplemental pharmacological interventions such as opioids in the postoperative area. It has also decreased the visual analog scale scores and enhanced patient satisfaction. The following are recent studies evaluating the addition of perineural dexmedetomidine to brachial plexus blocks. A randomized clinical trial performed by Huang et al. Revealed that the group receiving both ropivacaine and dexmedetomidine had lower visual analog scale scores, lower pain-related cytokines, delayed rates of rebound pain, and higher patient satisfaction scores. A study conducted by Karaki et al. Had comparable findings, where patients receiving dexmedetomidine along with ropivacaine displayed increased analgesic, sensory, and motor blockade duration, shorter sensory and analgesic onset times with no significant difference to the motor blockade onset. A study by Liu et al. Identified faster analgesic onset times, longer sensory and motor blockade duration. Patients that received perineural dexmedetomidine has also displayed a decrease in heart rate and MAP, along with an increase in SpO2 intraoperatively, which the author attributed as a favorable outcome. Verobeshnik et al. Had similar findings with the inclusion of intraoperatively transient bradycardia and hypotension. In continuation with recent studies, the research conducted by Barty et al. Revealed that the group receiving ropivacaine and perineural dexmedetomidine displayed faster onset of sensory and motor blockade, longer duration of analgesic blockade, decreased visual analog scale scores, decreased need for pharmacological interventions in the post-anesthesia care unit, as well as a decrease in heart rate and blood pressure intraoperatively, but no hypotension or bradycardia were noted. Lastly, a meta-analysis conducted by El-Baghdadi et al. Demonstrated that the group receiving both ropivacaine and perineural dexmedetomidine had enhanced analgesic blockade quality, a shortened onset time, and prolonged duration of blockade. The literature review also revealed that dexmedetomidine was associated with a higher risk of excessive sedation and transient bradycardia. Take-home points for this educational module. Dexmedetomidine is a highly selective alpha-2 adrenergic agonist with sedative, analgesic, and anxiolytic properties. Brachial plexus blocks with the addition of perineural dexmedetomidine have been shown to shorten the speed of onset and prolong the duration of motor, sensory, and analgesic blockade. These positive results have decreased the need for supplemental pharmacological interventions in the post-anesthesia care unit, decreased the visual analog scale scores, decrease the negative effects of both postoperative pain and opioid administration, thus enhancing patient satisfaction scores. Dexmedetomidine is also associated with a decrease in mean arterial pressure, transient bradycardia, and excessive sedation with increased dosages above 100 mics. Here you will find the references used to compose this educational module, as well as the studies listed in the study discussion points.